स्मॉल ऍक्टिव्ह करून
आपण ऑनलाईन करू शकतो.
हा तुम्ही तिथे करा ना ओपन, म्हणजे तुम्हाला पण बरं पडेल.
आयडी काय आहे सर?
ते याच्यावर असेल ना NHS च्या साईड. सर तुम्ही लावा, कारण ऐकायला तुम्हाला आम्हाला नाही आलं तरी चालेल.
नाही कोणाला ऐकायची गरज नाही, यांचं ऐकायला तिकडे जायला पाहिजे. यांना काय ऐकायचं नाही.
सर सुरू करा सर.
सुरू करू का?
यस सर.
ओके ओके, थँक यू. Hello, good afternoon everyone. Myself Dr. Mangesh Ghadge, Professor and Head, Department of Forensic Medicine at Rajiv Gandhi Medical College, Kalwa, Thane. Today I will be delivering one of the lecture in the toxicology series. Most of the poisons have been covered by the teachers, and all the teachers, they have taught very nicely. Today I will be dealing with the agricultural poisons. When we see about the agricultural poisons, thousands, more than thousands substances or the compounds are used as the agricultural poisons. The farmers, they use it for the protection of their crops, and they're used as insecticides, fungicides, weed killers, mass herbicides. But the unfortunate part of it is that people get poisoned with this. Sometimes accidentally. The people who are using this or engaged in spraying of these poisons may get accidentally poisoned because of inhalation, or the people who are actually engaged in the manufacture of these substances. Sometimes there may be deliberate consumption of these poisons with the intention to commit suicide, and very rarely it may be used or misused as the homicidal poison. Now in today's lecture, we are going to learn about, or what are our specific learning objectives in today's lecture. We are going to see about the classification of these agricultural poisons. It's very important, since we can know about which are the chemicals in a particular poison, the properties of poisons, what are the physical properties of the poisons. They may be available as in the form of dust or emulsions or solutions, liquids. Then we are going to see about the various routes of absorptions of the poison. Then once they're absorbed into the body, how do they act in the body? That is the mechanism of action of the poisons. Then after absorption, what are the signs, symptoms, in how much time the symptoms appear? That we are going to see. The very important thing, that is the management of the patient, poison patient, or the line of treatment. If unfortunately, during the course of treatment, if the patient dies and the body is sent for postmortem examination, so what are the postmortem features that we see during the autopsy examination? And lastly, what is the medico-legal importance of these substances or the agricultural poisons? Now, how do we define the insecticides or pesticides? These are the compounds which are used to kill the pests, which may be insects, rodents, fungi, nematodes, mites, molluscs, or unwanted weeds and the herbs. The insecticides, these are used to kill or repel the insects. Rodenticides, which are used to kill the rats, mice. Herbicides, that is the weed killers. Fungicides, to kill the fungi and the molds. The nematicides, to kill the nematodes. And the other poisons. Today we are going to deal with the insecticides, in which the substances used are organophosphates. These are widely used. Organophosphate compounds, these are widely used as insecticides. The other substances are like carbamates, the organochlorines or the chlorinated hydrocarbons, paraquat, pyrethrin, and its derivatives. By coming to the organophosphorus compounds, these are the esters of phosphoric acid. Their main use is in the agricultural insecticides and fungicides. They are also used as household garden sprays and to kill the flies and the insects. Organophosphate compounds, actually chemically they are the esters of the phosphoric acid, and they are widely used as the agricultural poisons. Mainly they form two series of compounds, that is the alkyl phosphates and the aryl phosphates. In the alkyl phosphates, we have the compounds like the HETP, that is hexaethyl tetraphosphate, TEPP, that is tetraethyl pyrophosphate, OMPA, that is octamethyl pyrophosphate. The substances like compounds like malathion, dimiflox, demeton. In aryl phosphates, we have the compounds like parathion, chlorothione, diazinon, which is popularly known as TIC20, and paraxone. Now, in these compounds, the solvent used or the base used is the aromatic base or the aromax, and that is responsible for the kerosene-like smell of these poisons. When a patient comes to us or comes to hospital, you may get kerosene-like smell to the vomit, froth at the mouth and nostrils. Or if unfortunately the patient dies and when we get the body for postmortem examination, in that the body cavity, stomach contents, they have a strong odor, kerosene-like odor. That is because of the solvent or the aromatic base which is used in the manufacture of these compounds. Now we'll see the absorption, how they are absorbed into the body. The absorption is mainly through inhalation. When the farmers they spray, there is risk of inhalation of these substances. This can be absorbed through the intact skin, mucous membrane, and also through the GIT, that is gastrointestinal tract. Even when it goes into eyes, that is transconjunctival absorption is also there. The fatal doses of these poisons, the TEPP, the fatal dose is about 100 milligram
आता बोलो.
आता.
The fatal period after the consumption of the poison, if the patients are untreated, death may occur within 24 hours, or those cases who are treated, if the treatment is unsuccessful, within the course of treatment, within 10 days, the patient may die. Now, coming to the mechanism of action of organophosphorus compounds, for this, we have to go a little back in physiology to understand the mechanism of action and the biochemistry of the neurotransmission of the impulses across the synapses. As all of us know, that at the neuromuscular junction or myoneural junction, the acetylcholine is produced, and which is responsible for the transmission of impulses across the synapses. This acetylcholine is readily hydrolyzed into choline and acetic acid, and this hydrolysis is greatly enhanced by the enzyme acetylcholinesterase. Now, organophosphorus compounds, these are the powerful inhibitors of carboxylic esterase enzymes, including the cholinesterase enzymes. So they bind or they inhibit these enzymes by way of phosphorylation. Some of the enzymes, they may restore activity within 24 hours, but some of the enzymes, they are permanently phosphorylated or inhibited. There are two types of these cholinesterase enzymes. Cholinesterase, they are present in the red cells, which are called as the true cholinesterase. They are present in the red cells, skeletal muscles. Pseudocholinesterase, which are present in the plasma, heart, pancreas, brain. So these enzymes are irreversibly phosphorylated. As a result, the enzymes, they lose the alkyl group and they cannot hydrolyze acetylcholine. So as a result of this, the acetylcholine goes on accumulating at the neuromuscular junction, and then what we see is the symptom like the overactivity of the acetylcholine. This acetylcholine, the receptors, and three distinct types of the actions we see. What we see is the three distinct types of actions, that is the muscarinic, nicotinic actions, and the CNS actions. Now here is picture that what happens at the neuromuscular junction in case of the organophosphorus compound poisoning. Now coming to the clinical features, in case of acute poisoning, generally the oral and the respiratory exposures, they result in the signs and symptoms within 3 hours, while in case of the skin absorption, the symptoms may be delayed up to 12 hours. Now, whatever clinical features we see, these are the muscarinic effects, then the nicotinic effects, and the CNS effects. Muscarinic effects, here it affects the pupils, the bronchial muscles. There is constriction of the bronchial muscles, pupils, they are constricted. It acts on the, or it affects the urinary bladder and the glands, sweat glands, lacrimal glands. salivary glands. So whatever symptoms we see because of the muscarinic effects, like on the heart it produces the bradycardia, hypotension. On the respiratory system, rhinorrhea, severe respiratory distress may be seen. Then in the GIT symptoms, nausea, vomiting, abdominal pain, it can lead to diarrhea also. It affects the urine, therefore we may see the incontinence of urine. Because of action in the eyes, we see the meiosis. And as I said, the glands are stimulated. Therefore, we'll see the increased lacrimation, salivation, sweating. There is one effect that is called as porphyrinemia, called as the chromolacriuria. It is the shedding of the red tears, but that is a very, very rare symptom. That is a very, very rare effect. It's called as the shedding of red tears or chromolacriuria. We can remember these symptoms by mnemonics. Easily we can remember these symptoms, like sludge. That is, as I said, it increases since it affects or stimulates the glands. Sludge, that is salivation, lacrimation, urination, diarrhea, GI and emesis, that is vomiting. Or we can say dumbbells, that is diaphoresis and diarrhea, meiosis, bradycardia, bronchospasm, vomiting, lacrimation, and salivation. Now, nicotinic signs and symptoms include these. The nicotinic receptors for acetylcholine, they are mainly in the skeletal muscles. So whatever symptoms we see because of the effect, means the skeletal muscles are affected. So here we see like the cramps in the muscles or weakness of the muscles, diaphragmatic failure, hypotension, bradycardia, and ultimately it leads to paralysis. Because of CNS stimulation, it leads to the headache, giddiness, restlessness, slurred speech, ataxia, delirium, convulsions, ultimately coma and death of the person. Now, signs and symptoms. Before I go to the actual signs, means we have seen the signs and symptoms, but they depend on the balance between the stimulation of this muscarinic and the nicotinic receptors. And also it depends on, as we must have learned this in the general toxicology, that is the signs and symptoms, it depends on many factors. That is the dose or the quantity of the poison ingested or inhaled. Then it also depends on the route of absorption, the rate of absorption, the rate of elimination also. And of course, the individual factors are also there. That is the age of the person, sex of the person, the condition of the body. So signs and symptoms, they depend on these things. So as a result, one more thing is there, that the route of absorption by inhalation, this is the fastest route of absorption. And the absorption by skin or through the mucous membrane is very, very less as compared to the route of inhalation. And the other route, that is through the GIT after the ingestion of the poison. So as a result, we see the severity of the poisons. In mild poisoning, the person may have the nausea, malaise, minimal muscle weakness, cramps. When, as I told you, there is drop in the activity of the acetylcholinesterase because of the irreversible phosphorylation. If this activity falls to 20 to 50% of normal, we see the mild poisoning. In moderate poisoning, as we have described, what is sludge, salivation, lacrimation, urination, the diarrhea, GIT upset, and vomiting. Along with this, we have tremors, weakness, fasciculations, confusion, lethargy, anxiety. Here, the ACH activity is 10 to 20% of normal. And severe poisoning, along with the sludge, the most important thing is here the person has the respiratory insufficiency. That is a very important thing. And later on, person may go in convulsions, coma. Here, the activity of the acetylcholinesterase is falls below 10% of the normal. There is one thing that is called as intermediate syndrome. It occurs after the resolution of acute cholinergic crisis. We see this after 1 to 4 or 1 to 5 days after the exposure, and it is characterized by the acute respiratory paralysis, muscular weakness, cranial nerve palsies. It persists for 4 to 18 days. Person may require the mechanical ventilation, and it may be complicated by the superadded infections, cardiac arrhythmias. Sometimes we may see the delayed symptoms after about 1 to 4 weeks of the poisoning. And this is seen especially in few compounds like the parathion and malathion. So initially it begins with just pain or cramps in the calves, and which is followed by the ataxia, weakness, and toe drop. Later on, it rapidly progresses to flaccid paralysis, ascending paralysis, and it resembles or it is similar to ascending paralysis or what we see in the Guillain-Barre syndrome, which follows the muscle wasting. Now, chronic poisoning, as people suffer from acute poisoning, people do suffer from the chronic poisoning also. And actually what we have seen, chronic poisoning occurs in those people who are that is an occupational hazard in the agricultural people, or those who are exposed, those who are actually engaged in the manufacture of these compounds. So route of exposure is obviously, or its inhalation or the contamination of the skin. And the main feature, important feature, is polyneuropathy, in which we have the muscle cramps, weakness. Sometimes the person may suffer from the gait disorders, and in the CNS effects, the confusion or the constant irritability, anxiety, or sometimes you may see some psychiatric manifestations. Now here you can see the overall picture of the sign symptoms, or which systems are affected. Almost all the symptoms are affected because of the organophosphorus compounds. You can see here. This is a very good picture showing the affection of almost all the systems in the body because of organophosphorus compound poisoning. Now coming to the cause of death, once the person is poisoned with this compounds, the important cause of death is, as we have seen, it is the respiratory failure, the paralysis of the respiratory muscles, which leads to insufficiency. The other is, along with the respiratory failure, means paralysis of the respiratory muscles, we have the failure of the respiratory centers in the brain. And one more thing, as we have seen during the muscarinic effects, what we were looking for, it acts on the bronchial muscles and causes intense bronchoconstriction. And that is one of the cause of this death. In the other causes, hypoxia or convulsions can lead to death of the person. Now, diagnosis, this part is very important, and it is the skill of the doctor. As soon as the patient comes to us, the doctor has to take a detailed history. Most of the time, the relatives, they are reluctant to give the proper history in fear of the police investigation. We can get the history from the relatives if the patient is conscious, cooperative. We can get the history from the patient also. But then it becomes the skill of the doctor to extract the exact history, what actually happened. And if it is, if the history is given that consumption or inhalation, we should inquire with the relatives whether they have brought the container of, so that we can know the chemical, which chemical is actually inhaled or consumed, and which the proper antidote we can use for it. So the proper history, and then the clinical examination, as we have seen during when we are talking about the alkyl and aryl compounds, especially the organophosphorus, because the base is aromatic, typical the kerosene-like smell during examination we can have, and the other clinical examination, respiratory insufficiency, or that we have to see. The confirmation of the organophosphorus compounds, it can be done by the estimation or determination of the cholinesterase enzymes. For this, we have to take out the blood, 5 ml heparinized blood, and we have to send it for the cholinesterase determination. Now, cholinesterase, as I told you, it is present in the red cells and in the nervous tissue, in the plasma. The enzymes in the plasma, they are very sensitive, and the level it in the poisoning, it falls rapidly. So if you see that there is fall in the cholinesterase enzymes in the plasma, but if the fall in the red blood cells is not that significant, we can say that it is the mild poisoning. So the confirmation can be done by the cholinesterase determination of the cholinesterase enzymes. Now, this is the very, very important part that is treatment of the person, treatment of the patient who is poisoned. So as soon as the patient comes to us, the doctor has to take a detailed history, inquire about what was actually consumed. This detailed history is very important. We should see when the patient comes to us, that is his vital parameters, temperature, pulse, respiration, blood pressure, the levels of consciousness, and the other medical complications that we have to see. In the treatment, the patient should be removed from the source of the exposure. If he's there in the inhalation or his spraying area, he should be removed from it. Then should be seen that whether his clothes or his body is contaminated with the compounds. If it is contaminated, it should be thoroughly washed with soap and water. Sometimes there may be a need, if looking at or when we see that if there is respiratory insufficiency or patient is going respiratory failure, we may have to do the tracheostomy. Tracheostomy may be required for this. And this is regarding the inhalation of the poisons. But if the poison is consumed, ingested, in that case, we have to take out the poison from the stomach or from the. For this, we have to do a procedure that's called as gastric lavage, so that we can take out maximum poison from the stomach. This is done effective if it is done as early as possible, after 48 hours or 36 hours, even if it is when most of the poison is absorbed, it may not be useful. So as early as possible, the stomach wash should be done. We can use potassium permanganate in a concentration of 1:5,000. Potassium permanganate being a strong oxidizing agent, it oxidizes most of the poison, and therefore it proves very, very useful during the gastric lavage. Then comes the specific treatment or antidotal treatment. The antidote for the organophosphorus compounds is atropine. In pharmacology, we have already learned that different types of the what we call the it is competitive inhibition. It competes for the same receptors. And atropine, it blocks the muscarinic effects due to the excessive or the accumulation of acetylcholine. The loading dose 1 to 2 milligram IV or IM, it's an adult dose. For children, it is 0.05 milligram per kg IV. It should be repeated every 15 minutes until the end point is reached. Now, you may ask, what is the end point? What effects are seen because of the injection of the atropine? As we have seen that in the muscarinic effects, the pupils are affected. There is constriction of the pupils. So after giving the atropine, there should be signs of atropinization, that is the dilatation of the pupils. As we have seen that because of the muscarinic effects, there is stimulation of the glands, exocrine glands, which lead to lacrimation or salivation, excessive sweat. So we should see that all the secretions are dried, the heart rate and the blood pressure comes to normal. So here we once again come to the endpoints, that is drying of the tracheobronchial secretions. When we auscultate the chest, it should be clear. No wheeze should be observed. We can keep the patient on maintenance dose, that is continuous. We can infuse less than 3 milligram per hour, or initially means the 10 to 20% of the loading dose per hour. And if there is signs of withdrawal, the atropine toxicity, we should withdraw. Now these are, along with this atropine, these substances, we call them as auxins. These are very, very important substances and which should be used in the organophosphorus compounds. They are said to be the reactivator substances. Means what we have seen in the mechanism of action, that the organophosphates, they inhibit the enzymes by phosphorylation. Auxins are the substances which reactivate them. And the commonest auxins used are the pyridoxine, that is palm, pyridine 2 aldoxylmethiodide. The current recommendation is to administer within 48 hours of OP poisoning so that they are more effective. Dose for an adult, it is 1 to 2 grams, that is 20 to 40 milligram per kg body weight in 100 ml normal saline or dextrose 5% solution is given IV for 15 to 30 minutes, and it should be repeated in 1 hour if person complains or the muscle weakness is not relieved. And then it can be repeated every 6 to 12 hours for 20 to 48 hours. Now this actually is the important part regarding the organophosphorus compounds. We have seen that about the mechanism of action, the treatment, all these things we have seen. But one should not get poisoned with this. So what are the preventive measures? So those who are engaged in spraying of these substances, of course, they should wear the protective clothing. The washing of the face and hands after each spray. And one more thing should be done, that is not more than 2 hours. The spraying work should not be continued for more than 2 hours. And even if one is spraying this, not more than 6 consecutive days, he should do this work. And person or the people who are already suffering from some respiratory illness or cough, cold, they should not do this work. And when the area is sprayed, in that area especially, the smoking should be avoided, or chewing of tobacco, drinking of alcohol, all these things, they should be avoided. These are the preventive measures. Once one who take all these precautions, chances of poisoning or may not be poisoned with the substance. Now, of course, in unfortunate cases, where the person dies during the course of treatment because of, or the treatment is unsuccessful. So the cause of death should not be issued, and the body should be sent for postmortem examination by the doctor. With all these requisitions, when the body comes for postmortem examination, we do the postmortem examination, external examination, internal examination. If it's a fresh case, as I told you, the kerosene-like smell, we may have a kerosene-like odor, characteristic odor. And what we actually see is signs of asphyxia, since respiratory failure or respiratory paralysis is there. And what we see in the postmortem examination is the signs of asphyxia. Therefore, the face will be congested. There will be cyanosis, central cyanosis, peripheral cyanosis. Sometimes we may have the blood-stained froth, which can be seen at the mouth and the nostrils. And when we actually open the body in the internal examination, when we are doing the internal examination, when we open the stomach, it will have these contents and they will be smelling like kerosene. The mucosa, it will be congested or hemorrhagic. Sometimes the petricial hemorrhage will be seen. Lungs, gross congestion, brain, all the internal organs, they are congested. The lungs will show the gross edema, even the brain will show the gross edema. And the rest of the organs, most of the organs, they are congested. When we complete the postmortem examination, during the postmortem examination, we have to preserve the viscera for chemical analysis. That is the stomach and the intestine with their contents, liver, spleen, kidney, pieces of liver, spleen, kidney in separate bottle, and blood. So all these things, they should be labeled properly, and they should be handed over to the police, so that after the chemical analysis, when the report is available in the department, we can finalize the cause of death. Now we have learned about the important insecticides. This organophosphorus, they are widely used as the insecticides, but there is other group also, which are called as the carbamates. And these carbamates are the compounds, they are derived from the carbamic acid. As compared to the organophosphorus compound, they are less toxic, or the symptoms, whatever we see, they're not as aggressive as the organophosphorus, what we see in organophosphorus compounds. And they are available in the form of dust or the solutions. The examples we can give here, that is Zaldicar, Temic, Propoxol. This is very well known. This Begon is familiar. Carbaryl or Sevin. Mechanism of action, it is almost same. Here in the organophosphorus, we have seen that there is irreversible phosphorylation. In this case, carbamates, it is the inhibited by way of carbamylation. Signs and symptoms, as I told you, they are less severe and of short duration as compared to the organophosphorus compounds. And there is similarity. Signs, symptoms, they are almost same as we see in organophosphorus compounds. Treatment is also same. It differs at one point that oximes, they are not of much help in the case of the carbamate poisoning. Atropine, it should be given. Then other group in these insecticides, the organochlorines or chlorinated hydrocarbons. Organochlorines, these are used as pesticides, and they are classified in four main categories. That is DDT and their analog. Example, DDT, that is dichlorodiaphenyl trichloroethane. Then the other compounds, the benzene hexachloride group and indene. The third one is cyclosidine and the related compounds. Example, aldrin, dialdrin, endosulfan, endrin. Then one more compound is there, that is the toxaphene and the related compounds. Physical properties, they are available as powder in the powder form. They are also available as the emulsions, granules, and in the form of solutions. Fetal dose, DDT and linden, it is 15 to 30 grams, whereas the aldrin, dieldrin, endrin, it is 2 to 6 grams. Coming to the clinical features because of these chlorinated hydrocarbons, acute poisoning and chronic poisoning. In acute poisoning, the symptoms on various systems, as per the various systems, nausea, vomiting, hyperesthesia. These are seen. In the CNS, we have the headache, vertigo, eye movement, twitching of the eyelids, confusion and convulsions. In chronic poisoning, it is because of the long-term exposure to these compounds, and ultimately it results in a cumulative toxicity. And some of the manifestations which we see are because of this chronic poisoning: weight loss or tremor, weakness, ataxia, oligospermia, and lastly means the increased tendency for the leukemia or aplastic anemia. Sometimes can lead to the liver cancers. Treatment almost same as that of the what we treat in OP poisoning in organophosphorus compounds. That is, in case of ingestion of the poisons, we should do the gastric lavage, take out the poison. Maximum poison can be taken out by this route before the absorption, before the actual absorption. Gastric lavage should be done. Now here, little bit difference is this convergence. They should be treated with benzodiazepines or phenobarbital in the usual way. And one more thing is there, that is cholestyramine. It's a non-absorbable bile acid binding resin, and that is effective. Means it causes or enhances the fecal excretion of this organochlorine compounds. And then, as per the symptoms, general symptoms, whatever symptoms are there, we should treat the general symptoms. Now, coming to the last part of this agricultural poisons, is what is the medical legal importance or the forensic importance of this. As we know, there is wide use of these substances, and therefore people are getting poisoned because of this. As here it states that accounting for estimated 3 million cases worldwide per year. These poisons, they should be kept away from the pediatric age group. We can see, sometimes we see the pediatric age group, since they are easily available in the market and relatively they are cheap. They are used as the suicidal poisons. Nowadays, these are becoming the common suicidal poisons. Homicides, as compared to, means these are very, cases are rare, but still they are reported. There is one more thing, that whatever the sample or the gastric lavage sample we collect, or when the patient comes to us, whatever vomit or what we collect, it should be collected, preserved, and handed over to the police. Nowadays, once again I repeat that these are becoming the common suicidal poisons because of the easy availability, and the cost-wise they're relatively cheap. Thank you so much for being patient and listening to me. Thank you very much.